Good morning everyone and welcome. Today is the 15th of June and it's 10 o'clock. Do we have any apologies for today?
Good morning, Chair. I've received apologies from Councillors Brown, Dougherty, Parton, Woods, Mandry, Bolton, Stevenson and Adams.
Okay, thank you. Do we have any declarations of interest? Okay, so we're going to approve the minutes of the meeting held on the 23rd of March 2026. Can we take this as a... Sorry, can we take this as a true record of the meeting? Yeah. I'd just like to say, as everyone can probably see on the agenda, that due to officer availability, we're going to have a look at the work programming at the end. So we're going to have the officers come first. So in light of that, I'd like to introduce the ICB and Miss Irvine. Thank you.
Thank you, Chair, and good morning, everyone. Can you all see and hear me? I can see you're looking at me, Chair, so hopefully you can see me.
Yes, we can.
Brilliant, brilliant. Morning, everyone, and massive apologies for not being able to be with you in person this morning. You will have received the report that has more of the detail. As requested in our work programme session, I have just pulled together a few slides so that we can spend most of the time in conversation. So we have met recently and talked through our 5-year strategic plan in some detail, but for the benefit of the conversation in public, to summarise, our 5-year plan focuses on the following. So neighbourhood-based models of care are absolutely vital in terms of our future direction. We want people that live locally to receive their care locally and as close to their home as possible. So we have been given the national directive and are very keen to work together locally to develop models of care for each and every neighbourhood within Staffordshire. The prevention will be the core theme of our work. In order to deliver this, there's significant transformation that will be undertaken across mental health, learning disabilities and autism, children and young people services, women's health, elective care, cancer and diagnostics. There are a number of shifts in the NHS 10-year plan, and one of those is absolutely about moving from analogue to digital, so supporting our population where they're able to access their records in a much more user-friendly manner via digital technology, and also where it's appropriate to support the use of technology in terms of diagnostics, but also conversations with their caregivers. What we will also be doing is modernisation of primary care in preparation for the full delegation of dentistry and optical services in 2027. What that means is that the budgets will be delegated to ICBs locally for us to make decisions locally about who and how and where we commission our dentistry and optometry services from. So again, making that much more appropriate via our commissioning and procurement processes. System productivity, which means obviously best value for money, will be driven through a value-based commissioning approach. So really looking carefully at our market, so understanding what the potential offers are out there and making decisions very much linked to outcomes rather than what a service could look like. What we'll be looking for is very specific outcomes and improvements to the health or the well-being of our population. We'll be standardising our care pathways. So again, thinking carefully about how we can make sure that everyone gets the same, regardless of where they live, when the conditions are appropriate to do so. We'll be improving our theatre and outpatient utilisation, strengthening our financial stewardship, and we'll be using our contracting methodology in order to do this in quite a different way than we've done before, all linked to the NHS modernisation agenda and reform. So our operational plans will deliver the key performance targets within 3 years, deliver a planned 5-year trajectory to an underlying break-even by 2030 to 31. So our financial planning is absolutely about a break-even position. We've worked through that. We've made significant progress from last year, and we are on track, having broken even last year, to being able to break even again this year, whilst maximising and prioritising our patient safety and the quality of care. We'll also be delivering capital plans across a range of areas, and the detail of that is in the main report. Challenges and priorities. So as I've mentioned, it's a challenging but deliverable plan, which is very much focused on financial sustainability and commissioning quality care. Our new operating model creates the opportunity to strengthen place-based working and a shift towards a more innovative and outcomes-based commissioning. You will have seen in the 5-year strategic plan, in the conversation we had a couple of weeks ago as well, very much much more detail in terms of how we intend to work and how we intend to deliver those services, both as an ICB, but working really closely with our partners at Neighbourhood and Place. Of course, there's risks to the delivery of the plan, which is including the reduced ICB workforce capacity, but we have mitigated those risks, as you can imagine, in order to maintain pace and to make sure that our population is at the priority of the work. Reducing health inequalities and delivering through partnership remains central with our local population health improvement plan, our integrated strategic needs assessment, and coordinating the system work underpinning the implementation of this. Financial sustainability is always a priority, but the board's position, all of which this work has gone through our boards, is that this must be delivered without in any way impacting on the quality of the services we commission. And the ICB will work closely in partnership with the system partners. And what we mean by that is NHS organisations, our local authorities, absolutely, and very much with our voluntary sector colleagues as well, and the population, so that they have the opportunity to input into the services that they want to see, and that we can talk to them about any changes that we intend to put in place. In terms of the complaints data summary, I'm not going to go through all of this in a massive amount of detail, but you can see that we had 834 formal complaints. The principal themes were around all-age continuing care, predominantly around delays, particularly respective reviews, and people not happy with the outcomes of the panels where funding had been withdrawn or reduced. This is a massive focus for us in terms of the reorganisation of that team. There have been some significant improvements made already, but we are really conscious that this is an area that we need to put our spotlight on. So in order to do that, we've changed the way the team works, we've changed the skill mix in the team to ensure that we see continued improvement. 22% was around surgical procedures at non-NHS hospitals, mostly operations funded by the ICB, but cancelled at short notice by the provider. Again, we're focused on that internally. 6% regarding access to Manjaro, weight management medication, 4% regarding the change of commissioning policy for routine earwax removal, 4% regarding NHS special allocation scheme, and 4% regarding access to flash glucose monitors. In terms of any specific queries about those complaints areas, I'm more than happy to take that back. I won't be able to give all of the information about all of it if there are specific questions today, but I'm really happy to take queries and then be able to respond to you all. I'll stop there so that, and I'll stop sharing so that you can ask me questions, Chair, if you would like to.
Okay, thank you for that. Does anyone have any questions? Councillor Norman.
Ready's going to. The first thing is that we had a training session just a little while ago, and one of the things at the training session, and in fact all the training sessions I've attended in 20 years and so on, is you don't note reports, and yet we've got 2 of the 3 reports is down for noting. So, you know, can we make sure that doesn't happen in future? Our job is to scrutinise these things. The only question I've got for this section, I've got some questions on the appendices, Appendix 1, is that, you know, there's all this, and later on there's a report, it's even more complex and longer, I understand that. But for my purposes as a scrutiny member, is how it's progressing. So what I'm interested in, how will we see, what reports will we get? We'll make it clear that you are, that is, and I'm on your side in that respect, how we're progressing the plans that you have. That's what I'm interested in. There's all this stuff here. This is to negotiate with government and so on. But I'm interested in how we make sure that things are working as is planned by government, as is planned by the ICB and so on. So what sort of reports will we get in future where we can easily see the progress or otherwise of the plans? Thank you, Chair.
Thank you, and thank you for that question. And also thank you for inviting me to the work programme planning session that you had a couple of weeks ago. That's how you will see how we're progressing. So, and I know that the work programme's a bit later on the agenda. What we heard from you and what we then had conversations via Richard Harling, etc., was the kind of areas that you would expect to want to hear about in terms of our progress. So on the work programme, there will be specific items where we will come to you and you can scrutinise, linked to the development of neighbourhoods, linked to our UEC programmes, our winter kind of reflection, but also then going forward into next winter, mental health, etc. So you will get throughout the year via the work programme a conversation with us. We'll bring you the data. You'll be able to then scrutinise us to see actually what progress have we made and what changes and outcomes have we achieved for the population.
Just to say thank you. Yes, that's good. Good, thank you.
Okay, thank you. Councillor Wallins.
Thank you, Chair, and good morning to you, everyone. And thank you for the report as well. I've just got two questions on this one. Looking at the report, there is, as you know, 834 formal complaints that was made between 2025 and 2026. And the key issues to that, from what was highlighted from the report, was delays and cancelled private operations. I was wondering what changes are being made based on the complaints trend, obviously to improve and to lower the formal complaints.
Thank you. The majority of the work there is via our links with our independent sector providers, so the providers that we commission from, to make sure that we've improved our communication. We're really clear on the outcomes and the contract methodology with them. We do liaise directly back with the individuals concerned. We've got quite a significant action plan as well. So you'll see in the report that one of the metrics that we're not as robust on, the only red one out of all of the green, is around the outpatients return to treatment targets, which again, this is very much linked to the question you've just asked. So we are expecting to see significant improvement. It's very much the focus of our delivery director on that in the way that we work with our providers. If you'd like me to give you some more information that's really specific, I can ask Phil, who's the officer for that, and I can come back via Zach.
Yes, I will happily love to request that information. I don't know if Zach wanted to come in on that one. Okay, that's fine, thank you. And thank you for the answering the question. The only other question I got is, how is the ICB ensuring financial balance doesn't affect care quality?
So as I've mentioned, this is absolutely our focus. So, and we've done this all the way through. So all of the programmes and projects that we put in place, the transformation that we put in place, to consider value, to consider productivity, as well as obviously the most important bit being the quality of care. All of those programmes go through our governance within the organisation and work with partners. So we have EQIAs for all of those. We consider what the risks could potentially be, if there were to be any, from various lenses: finance, workforce. We think about the impact on the patients. They are through contract management, but also through our reporting mechanisms internally. Constantly, the outcomes are being considered. There are a number of different metrics that we use for that. So there might be attendances, there might be improved outcomes in terms of reductions in the need for certain areas. We liaise with our providers. We've got a quality group which looks at all of the quality metrics. All of that information is triangulated and goes up to our board. So we have the governance in place to ensure that nothing that we do has got the negative impact. And we're also always looking back to monitor actually have we seen those improvements going forward. And as I've mentioned, the contract mechanism has changed and will change, much more focused on outcomes rather than, for example, we would like you to put a clinic on between these times in the week, or we want you to do this service from this hospital. It's actually saying how many patients have been seen and what were the improved outcomes for them. So it's very much changing what we look at and what we measure. And again, that will be coming through governance, and through the work programme throughout the year, we'll be able to tell you about each specific area.
Thank you, and thank you as well.
Okay, thank you. So, Councillor Luca, did you want to ask a question?
Good morning. Yeah, my question is based around the mental health. Obviously, you've got the talking therapy. That's already not actually working, because if you look at the figures, it's constantly behind where it should be. And when I've done digging, the dropout rate, and this is not because they don't want the help, it's the time waiting to get the help, is nearly 50%. So what are you actually doing to improve that? And also, are you going to actually ring fence the funding for mental health services in the community?
I will have to go back and ask an officer to give a specific response regarding talking therapies. There are metrics within the report on that, and they are all green in terms of the reliable recovery, reliable improvement, and talking therapies completed courses. But I do acknowledge that, you know, from a patient and client experience perspective, there have been concerns raised about delays for the first appointment. If it's okay with you, Chair, I will take that back and ask the question and revert.
Okay, thank you. Councillor Greatorex.
Thank you, Madam Chairman. I've got two comments or questions, one relating to the operational plan and one relating to the complaint summary. If I just go with the operational plan to start with, it is something that I've raised before, about this time last year, that what we've got is a very top-level operational plan. Top level in that it describes the principles that are being taken over the next 10 years, things like hospital, the three shifts, hospital to community, analysis to digital, analog to digital, and sickness to prevention. On our page 21, we've referred to the need for a headcount reduction, but also a revision of the model. And then in the summary, which is towards the end, obviously, the 5-year plan to get to break even, achieve all the KPIs within 3 years, and cover the capital plan. So that top level doesn't give us any indication of what's going to happen when. And I've said this before, if we're going to have confidence that this is a plan that's going to work, we need to have more detail. It's got to work in two respects. It's got to be achievable, and I dare say there are people in strategic planning within the ICB who are confident that this is going to happen. But there's nothing in the way of Gantt chart or a process plan which gives any indication of how these things are going to be achieved. So, for instance, one of the things might be to change one of the processes and stop doing something in one direction and go and do something differently in another direction. But at the same time, you've got headcount reduction. So how do we know that whatever's going to be A and B happen before C and they all coincide? The whole idea of it being a plan is to coordinate. So unfortunately, we don't see any detail. I know the document that we've had, which we've had circulated, refers to the ISNA, the PHIP and the clinical strategy documents. We haven't had enough chance to detail, see that amount of detail. So my comment specifically on the plan is very much as I've raised before, and similar to the other agenda items, to be fair. They are top level. How do we have the confidence that it works for yourselves, that it's going to be achievable? But secondly, what are the repercussions for our residents? Because what we're hopeful of being able to ascertain is whether things are going to fall over and patients are going to be affected, residents are going to be concerned by detail.
Thank you. And I do understand your request for detail and wanting to understand exactly what's going to happen when. We do have our strategic objectives, we do have our strategic plan, we have our operational plan for delivery in year. As I've mentioned, we'll be coming to talk to you about each programme area in the work programme, which covers off more detail on each of these as we go. So we'll be able to talk to you about what our targets were, what the outcomes were we expected to achieve, and then obviously our performance against them as an ICB. I acknowledge that you want more detail. I understand that. I think from a public scrutiny perspective, we are able to share certain documentation, which is of course strategic, of course it's high level. We're working internally with our partners to develop particularly the neighbourhood methodology. So exactly what will that look like? What will that feel like? What are the changes that our population will see? And in fact, I think you were there at the work programme meeting last couple of weeks, I did suggest that neighbourhoods, for example, came to you for scrutiny so that you can see what we've done, when we intend to do it, and actually have we achieved those outcomes. So understand that the frustration. In terms of some of that documentation, if you let Zach know, I can actually get that for you and send it back out. But I do think some of this is evolving, and we are working with partners on it. And on that basis, we don't have all of the detail at the moment to share in a public forum. But we would want and need you to scrutinise us as we go throughout the year on it.
Yeah, thank you. I welcome I did attend the workshop, so I know that you did refer to that. And I'd welcome the greater detail, which gives us more chance to see some confidence in what's being suggested. If I go on to the complaints summary, I'm a bit of a statistician, so I tend to focus on figures a bit too intensely, but it's been referred to by Councillor Norman or Councillor, I'm not sure who it was, 830... Yeah. 834 formal complaints, 146 relate to the ICB, and it seems to be that in the document you're trying to explain away the 146 because it later goes on to say that 23 were down to a age coordinating care delay, and then a further 25 were complaints about a cancelled surgery, which seems to be explaining away the 146. My bigger concern is the 688, which are referred to as being service providers, as if to say, well, it's nothing to do with the ICB because it's the other service providers that are responsible for those complaints. I'm afraid the ICB is responsible for its service provision, and therefore the service providers need to be brought to account. So can we have some assurance that those 688 are being investigated and developed into whatever direction they need to be with the providers?
Absolutely, they are. And apologies, perhaps the report wasn't clear in that regard. So when we do have complaints linked to our providers, they're absolutely shared and expected to be responded to by our provider organisations. So in terms of those that related specifically to us, we are able to share that information. And I know that you've got colleagues here from provider organisations here today, so I'm sure that, and maybe I shouldn't actually assume this actually because they're here for the operational plan, but if you would like me to send something to Zach to explain what the process is for providers that then have to respond to complaints, I can, but actually providers absolutely have a complaints process, and what they would tend to do was to either respond directly or to respond to us, and we would then liaise with those. They're not ignored, they're absolutely looked into with this in the same robust manner.
Thank you. There is a quick question that I'd like to ask on a follow-up to that. It says that you yourselves have had 146 complaints, 34 didn't progress, 9 were resolved. In regards to this, which would leave 103 sort of as an outlier, in regards to that and the other complaints, what is it that how are they then further dealt with in the way that why have they not been resolved or been, you know, yeah.
So, sorry, I lost you there, Chair. So,
Sorry,
could
yeah,
you
I'm
repeat
sorry,
the
my
question? I couldn't
thinking
hear.
process was a bit confused then. I do apologise. Right, so you had 146 complaints, yeah, and 9 of those were resolved, with 34 had no progress. Can you tell me more about the ones that have not been resolved in the way of the 103? I mean, or would that be better to, when it says the process taken by providers, you said you could give us that. Would that more be something we could ask you for in a sort of a layout where you could provide us with how that is dealt with? Because I'd be very interested to know what happens to the 103 complaints you've had and what's happened with those specifically.
Yeah, if it's okay, if you could perhaps write, ask Zach to write to me to ask that specific question.
Yeah.
I'll be able to revert on that basis in the next couple of days.
And the other question I had was in regards to the wider complaints for all the services, is that a trend in where you have very few that were resolved, and what's happening to the rest that have not been resolved? So do you see anything in a trend across that, or is that just specifically for the ones for the ICB?
In terms of comparison with provider organisations, you mean? So is it a trend that we're seeing across the NHS?
Yeah.
Again, apologies, I'm going to have to liaise with my complaints colleagues and provider organisations to compare that, to make sure that what I'm telling you is accurate in terms of any trends there.
Okay, thank you. Thank you very much. Councillor Bassett. Oh, sorry. Health Watch Bassett. Sorry, David Bassett.
Right. I've got 3 questions for you. We're rapidly approaching the end of Q1 in another 2 weeks. How's the money going?
Yeah, so we're progressing in the way that we would expect to towards the end of Q1. There have been some slight overspends in certain areas, but that's something that we'll mitigate and we'll kind of address. CHC is an area that we do really struggle with from a financial perspective in general across the NHS, and obviously the demand on that service is significant. But there are no significant concerns to report at the end of Q1, but we're not quite there yet.
Yeah. Okay, second question is, you mentioned listening to patients. How do you propose to do it in the new world?
Okay, so we have got an involvement strategy that's going to our board on Thursday, so a week on Thursday. It's a really robust strategy which indicates that what we will do is we'll meet with a number of different colleagues to help to evolve our methodology for this. So we've got a workshop with BCSE colleagues, we've got our People and Communities Assembly tomorrow, and our lived experience forum. We've actually met with a number of lived experience colleagues across of Staffordshire to help them tell us how best to work with the public. Because actually we could come up with all kinds of forums, digital forums, we could go out to meet with community groups. But what we don't want to do is to spend the time doing something in the wrong way, in the wrong place, so that we can't hear from the people that we need to help resolve and kind of not resolve, develop our services. So we're doing almost a you tell us. So that the strategy is very clear. It very much links to our commissioning intentions, and it will be focused in those areas that I talked to you about a couple of weeks ago. So CVRM, frailty, mental health, children and young people, SEND and learning disabilities. So what we need to do is harness the knowledge and the, I suppose, the passion of our population so that we can help them to feel heard, but in the right way. So it will probably be forums like community groups. It will probably be that we offer a number of different methodologies, like some people might want to answer questionnaires, some people might want to join online forums, some people might want to actually have us go into their groups. But actually what we need is your help. when you're meeting with your constituents, your populations, if you're hearing trends, and this is a conversation, again, I think we had, was, you know, this is a two-way conversation. If you're hearing things, please do let us know. And if there are groups that you think we would benefit from speaking to, again, let us know, because that is the way that I would want to work with the local authority, because you have a lot of access to our population as well.
Okay, and the third question, which kind of links in a way with this, there are almost 80,000 people in Staffordshire and Stoke with diabetes, and according to the feedback we're getting from some of the groups that work with diabetes, Staffordshire doesn't appear to have a coherent diabetes strategy or plan in place. We are outliers compared with neighbouring authorities like Derbyshire and Leicestershire in terms of the service we provide. And I understand that from the feedback I've had from the public anyway, that there's a lot of frustration around that. There doesn't appear to be a coherent diabetes strategy in place. And I'm also told that diabetes and its side effects and whatever actually contributes to about 10% of the cost of the NHS budget.
Yeah, I mean, you're right that diabetes is a national concern. As just mentioned, one of our priority areas is cardiovascular, renal and metabolic conditions, metabolic being the bit that links to diabetes. So long-term conditions is a huge priority focus for us. We have reduced our ICB workforce, but we have invested in the business intelligence team, colleagues who will be able to interrogate our data and really understand the areas that we need to focus. And diabetes is one of those. So we, in terms of a specific robust strategy, I'll have to go back and liaise with Lorna Clarkson, who's our Director for Strategy and Improvement of Health Outcomes. So I will do that for you, but I can tell you that diabetes is absolutely a priority for the ICB. I can't comment on the outlier part in Derbyshire, because obviously that's not our area.
Okay, thank you. Just to finish off on that one, linked to diabetes, apparently Staffordshire's got one of the highest rates of lower limb amputation in the country, and 51% of that is down to diabetes.
Sorry, was that a question?
Well, it's just a statement, really.
Okay.
We in Health Watch are doing some work with Diabetes UK and MPFT Podiatry at the moment, looking at that, and that's coming from patients upwards at the moment. So we need to link you into that as well, I think. Yeah.
Yes, thank you. And we are aware of the rate of lower limb amputations within our county. And therefore, yes, that is therefore a link to, and can be a link to diabetes, and therefore diabetes being one of our priority areas.
There's a consultant at Derby Hospital who I was talking to last week, who's the International Authority on Foot Health. So we've been talking to her as well.
Okay, thank you.
Okay, thank you. Councillor Griffiths.
Thank you, Chair, and thank you, Mish, for your presentation and your report. It starts off with, you went through a lot of change last year and integrated the ICB with, it even says above your head there, Shropshire, Telford and Wrekin, Staffordshire and Stoke-on-Trent. We are in Staffordshire, so it was nice that we only had a report about Staffordshire. What I'm worried about is if problems start to happen in Shropshire and Wrekin, does that affect us, or are you still separate somehow? That's my first question.
What do you mean by affect you?
Well, if you're just one combined ICB, surely if you're not performing in, say, Telford, doesn't that affect you as a whole and therefore affects us, or are you separated
in
somehow?
terms of our, okay, in terms of our outcomes and our outcome metrics. No, I mean, we measure everything separately, Councillor Griffiths. So we're able to identify, as just mentioned, we've really invested in our business intelligence data. So those are the guys that actually triangulate. So our quality, our performance, so our outcomes, and also linked to the finance, so that they're able to report that specifically to between Staffordshire, Stoke-on-Trent, Shropshire, Telford and Wrekin.
Thank you for that. And then, sorry, so you had 18.6 million of running costs. I just wanted to, what are running? Is this like keeping the lights on, or is this administration?
Yes, it's those things. It's our workforce. So how much we spend on the people that commission services in our ICB, as well as the kind of operational bit as well. So it's keeping the organisation running.
I mean, I had to check I was working out percentages right, because I got it. It's just very slightly over 0.5% of your budget is on administration. I think there would be a lot of companies out there who'd be very impressed with that.
Thank you.
And thank you, Chair.
Councillor Edgeler.
Thank you, Chairman, and good morning, everyone. Yes, I've got a few questions, actually. The first one, actually, is about mental health, and I reiterate what Councillor Lucas said, about children. We have got to do something about helping our children with mental health. And, looking at the waiting list for ADHD and, and the other problems they have, it's a long waiting list, and we really got to attack that. And also obesity in children, because we give the help to these children at that early age, you're going to save yourself a lot more money later on, if they get the help right at the beginning. So that's my first question. My second question relates to dentistry. We've had a lot of talk in this committee about dentistry over the last couple of years, actually. And I'm seeing now out in the community and saying, listening to people, what people are saying. So this is what people are saying. Yeah, dentistry. We're getting a lot of new dentists, but they're all private and they're so expensive. And people on a minimum income and that, are finding it very, very difficult to get their teeth looked at and seen to, which affects their health. So what can we do about that? My third question, actually, is about, all right, the growing number of population in Stafford. I know we've got the new centre being opened in the Stafford County Hospital. Are there any more plans to improve the services at County Hospital over the next 5 years? Because the number of people now that's coming to live in the area, and it's such a growing demand, and knowing that the problems we've got at UHNM with A&E waiting time. So what can we do about that? And really, this is a very simple question. Do all the hospitals talk to one another with the records, with the technology? Because I find if you go to one hospital, they don't talk to the other hospital when they're looking at your records. So can you make sure that all records are compatible throughout the system, please? Thank you, Chair.
Okay, thank you. I mean, I've written down your questions. So in terms of mental health and the waiting lists, especially in CAMS for ADHD, I think I've already said that we are really concerned about especially our young people waiting such a long time for assessments. And that's why that is one of our priority areas, both mental health and children and young people on its own. So that links to your second point around obesity in children. We are working really closely with the local authority as well on that. What can we do to improve our young people's understanding of making healthy choices, and the parents as well? So some of the work that we're doing in schools directly is very much about, yes, them understanding the wider determinants of health. So would you want to have a career either in health or care? And these are the types of people that do that. But at the same time, having the conversation about healthy life choices. And I'm sure that Dr. Harling will be able to talk to you as well about the work that the local authority directly are doing with schools in terms of, again, improving those messages, improving the facilities available for young people to be active and to also think about their mental health. So it's all about being a healthy, happy young person. Dentistry, I'm going to have to take that away. That's a very specific question regarding primary care in terms of the cost of dentistry. However, as I've mentioned in my presentation, we will now have the budget delegated directly to us in terms of dentistry. So I'll take that one away. The plans for County Hospital, we are going to be bringing the UEC potential changes to the committee over the next couple of months. I'm not sure I can comment much more on that at the moment, but we're going through the UEC performance over last winter as part of a work programme, I hope. Like a working group, so you can actually understand that in a little bit more detail, and then we'll be bringing a formal item around winter planning as well. We did talk about the records bit. Do the hospitals talk to each other? Again, we do understand this is a frustration. We're working constantly with the One Healthcare record, but also various other technologies to try and make it easier for patients to navigate the system. This is a huge push in terms of analog to digital, to have records that are available to multiple health providers. We need to consider the information governance constraints in this. We need to work through how we ensure that our population and our people's data is safe and only accessible to the right people. But if you would like a kind of briefing or an update, again, I'll have to take that away in terms of the detail on that, Councillor Edgeler.
Thank you for that, and thank you for listening to my questions. But can we also consider, you know, there's a lot of, when I'm talking about house building in Stafford and the number of people coming into the area, we're also looking at County Hospital, A&E. You know, it is an imperative part of people's, access to hospitals. So please, can you look at that and see whether anything can be done? Because, as I said, we're not talking about a few hundred people coming to live in Stafford area. We're talking about thousands of people. So please take that on board. And if possible, I know it's going to cost money and everything, but it's like everything in life, everything costs money. But if you could look at that, I would really appreciate it. Thank you.
Thank you. And I do think that the planning committee as well does have a role in this in terms of some of the processes of I suppose the technical process around resources. And I'm not going to comment on it because it really isn't my field of detail. However, from an NHS perspective, we absolutely look at the population when deciding actually what level of service is required in each geographical area.
Thank you. Councillor Norman.
Yes, well, next time I shan't wait. I'm getting quick with the appendices, but the questions are obvious questions, really, that members have asked on the complaints. But I'd just like to follow up with some other aspects of that. With regard to the process and the service providers, is there a further report that goes to the board, ICB, in that, where you follow that up and seeing who is the providers that are causing problems, who have been able to be successful? In other words, is there a further report on the detail of those complaints that at least go to the board, the ICB board? The other question is the overbooking by the private hospitals. Can I just ask, are the surgeries there, surgery procedures, are they varied, or is it particular sort of surgery, a common one like knee replacements or anything like that? Just mention on the earwax, I was amazed that I was offered earwax by a GP when I went to A&E once, but I suddenly became deaf, and all it was earwax. And what they don't tell you is that if you get it done once when you're older, it comes back quite quickly. You think, oh, I've got another 70 years before I need another one, but it doesn't work that way. So I was amazed with that being available on the NHS. I certainly didn't want that. And the last one was on the special scheme there for those people causing problems. 4 formal complaints regarding the service, most in respect to those patients being unhappy that they've been placed on the scheme, the special allocation scheme. Of those 4 formal complaints, do you know if any were upheld? I'm sure nobody wants to be on that scheme, but were they all upheld on that one, please, if you know?
I don't, and apologies. I'm going to have to take those 3 back, Councillor Norman, and I'll respond to you in writing via Zach.
Okay, Mr. Bassett.
Can I just go back to dentistry that Anne mentioned earlier on? I spent quite a few months last year researching community dentistry services in Staffordshire, and I work with the Shropshire and Staffordshire Network for Dental Services, which meets on a quarterly basis. There has been quite a significant amount of work done by the NHS on an equity audit looking at dental services, and there has been a redistribution of some of the money into areas particularly of greatest deprivation. Perhaps it's not unexpected that quite a lot of that is in Stoke, but significant moves are afoot to change the way dental services are commissioned. There's been a lot of change this year, and also there's an urgent line you can ring now for advice and access to emergency appointments, and we've written a guide to NHS dentistry in Staffordshire, and we've had it translated into Urdu, Punjabi, Polish, easy read, and BSL, and you're very welcome to have a copy of that.
Yes, please.
Yeah. Okay, thank you.
Thank you.
Is there any more questions from anybody? Councillor Luca.
Yeah, just going back to the reduction in headcount. In a previous report, we were told that it would affect 1,100 positions. How many of these positions now in this headcount reduction are going to be frontline staff? How many are going to be, obviously, like rear office staff? That's my first question. My second question is, under this proposal, what are you actually going to do to actually combat the problem with actually the front door? Because you're supposed to have 45 minutes to do a handover from ambulance to hospital. I mean, as I drive ambulances, I know that doesn't happen. We've spent entire shifts where we've been parked outside of a hospital with a patient in the back because we can't get the patient in. And also, what is this budget going to do to corridor care?
Thank you. In terms of 1,100 colleagues being affected, I think that might relate to a different organisation. We don't employ, in the majority, actually frontline colleagues or clinical colleagues. There are some clinical colleagues that work for the ICB and the CHC teams and that support us around SEND and learning disabilities and quality. However, they tend not to directly support patients. So it may be a provider organisation that you have that stat from, and apologies if I've got that wrong. So from a frontline perspective, there's a very small number of colleagues that would be affected by any reduction. We are really clear that we need to keep our clinical teams robust, and actually will be ensuring that as a priority area along with the business analytical information. You've asked me a couple of questions about the UEC pathway around corridor care, handover delays. There will be an item that comes to the committee on winter and winter planning over the next couple of months. And I would prefer that the officer that's actually leading on that's able to answer those questions on the basis that that's more relevant, I think, to a very specific question on urgent care, a session on urgent care.
Okay, thank you very much. Thank you for your presentation. I would like to request to receive further information on your complaints in relation to outpatients and cancelled operations. Can we also receive a briefing around talking therapies? We would also like a briefing session to look at complaints processed and procedures for the ICB and the provider trust. Does everybody agree? Yeah. I would also like to say that I fully back up any comments that Councillor Edgeler made on the hospitals. and I would like to also put forward my concerns on growing population within Staffordshire, how many houses we're building, and the services that are actually being provided to the people of Staffordshire. And I think that this genuinely needs to be taken into account, and I'm sure it is. But I just want to put my sort of concern in that I hope that this is being taken into account when we're looking at certain provisions and what we are providing to the people of Staffordshire. Thank you.
Thank you, and thank you for the time this morning. Zach, I presume that you'll write to me formally outlining the request. I have made notes as well, but just to make sure that I don't miss anything, I presume that you'll be writing to me requesting that information.
Yes.
Great. Thank you very much.
Thank you, Mish. Okay, so next is UHNM, Integrated Delivery Plan, and it's Chris Bird. Welcome.
Oh, okay. Good morning. My name is Chris Bird. I'm the Deputy Director of Strategy at University Hospitals North Midlands. So thank you for the invitation to talk to you today. I'm going to talk a little bit to the report that we've published, and then more than happy to take any questions and comments that colleagues may have. So a little bit similar to the ICB and Mish's update. All NHS organisations have been required to publish a 5-year plan or develop a 5-year plan by March 2026. That was well timed for us. We'd just developed our new 10-year strategy that we published in May 2025. So we had a wealth of material to draw on. I think in the report we set the context out. So the national policy and the 3 strategic shifts around hospital to community, analogue to digital, sickness to prevention. We also talk about the alignment then to other health and system partners, ICB, but also colleagues from MPFT and combined healthcare as well as primary care. And we set out the need for the 5-year plan to essentially be a delivery plan for the 3-year technical submissions that we needed to make, predominantly around finance and operational performance. And in the appendix to the report, you'll see a list of operational measures that we need to achieve over the next few years. The 5-year plan then essentially, as I say, is our delivery plan. That's wrapped around 4 strategic programmes, which we've detailed in the report: Brilliant Basics, digital care, our future hospital, partnerships and collaboration. I won't go through each and every one of those in the interest of time, but I'm happy to take questions. There are some elements that I think just worthy drawing attention to. So we have already opened now the Community Diagnostic Centre in Hanley. That opened in May 2026. We've redeveloped the breast care unit at County. We are on track with building the urgent treatment centre at Royal Stoke. There is plans for similar, as Mish suggested, at County, subject to business cases, etc. We have a major programme of outpatient reconfiguration. We're investing in developing our digital systems and digital service offering, again aligned to national policy, e.g. expanding use of the NHS app. We have recently secured £12 million worth of inward investment to further expand our robotics surgery. That's already delivered a 20% uplift in productivity, saved the equivalent of 3,000 bed days, and as a result of our position in relation to robotics, we have been invited to host the West Midlands Robotic Network. And then we also set out a range of collaborations that we need to ensure are working effectively to support us on our transformation journey. So both with colleagues in this room, with the ICB, but also with primary care, including dentistry and general practice, and then other organisations such as the 2 local authorities and the universities. I think we've previously provided an update on the financial position in 25-26 and shared an outline plan for 26-27. So we've got some more detail on that in the report. I think it's fair to say that that will be one of the main challenges we experience over the next 3 years, returning to a break-even position in each of the next 3 years, but doing so at the end of year 3 without recourse to national support funding. And then just linked to that, we by invitation, we've set out a number of challenges. They are the same challenges that we shared with the ICB chair at a recent visit to UHNM, but it's about how do we deliver some of the immediate improvements that we know we need to make around urgent emergency care and our elective care, as well as transforming our service delivery for tomorrow. So hopefully that's a useful overview. I'm conscious of your time this morning, so I'm happy to take questions and comments.
Councillor Walling.
Thank you, Chair, and thank you for the report as well. I've just got 2 questions on this one. It's great to see the Community Diagnostic Centre in Hanley is obviously been opened in May, just last month. I was just wondering, what impact is the Community Diagnostic Centre already having on waiting times?
So it's a bit early to say for sure, because it opened in May, as you say, and we're just in the process of compiling the report for May. So we'll know more over the next few months, but what I can say is that the range of services that are being offered through the Community Diagnostic Centre will absolutely have a beneficial impact on waiting times and generally patient experience, because it essentially offers an off-acute site service provision. It offers more coordination of diagnostic services, so more of a kind of one-stop shop type offer. So we've not got definitive numbers as of yet, given the fact that it's only been open a few weeks, but I'm more than happy to provide an update later in the year.
Yes, I would love to receive a report of the details on how much of an impact it's having, obviously later down the road. Thank you for that. And the only other question I've got is, it's great to hear that obviously new centres being opened, new things being opened in across Staffordshire, but I don't know if this is in your remit, but do you have any updates regarding Burntwood Health Centre by any chance?
I don't have an update around Burntwood Health Centre. I think that's a health centre that's commissioned through ICB colleagues.
Cheers, thank you.
Okay, thank you. Councillor Edgeley.
Thank you very much, Chairman, and thank you for your report. Yes, I've got to say I've been a patient at the Community Diagnostic Centre in Hanley, and I've got to say I was very, very impressed. Very impressed. And the car parking is brilliant, not like the UHNM. and it's good to see that the Urgent Treatment Centre in Stafford, it's been on the cards for a long time, but now it's been put in operation. My main question really is people leaving the hospital, you know, and coming out into the community when they're needing care and everything. Is there any way that we can improve that in any way or any situation, you know, because that is one complaint I get quite a lot of. You know, people have been ill, they're in hospital. I'm talking about the frail and elderly really now, you know, as to what we can do to improve their outcome from when they're leaving hospital into back home, or is there any way that the hospital can build a unit, you know, so they can be put, I don't know the answer, I'm getting it to you the question actually. Is there anything we could do to improve it? Thank you.
So firstly, thank you for your feedback on the Community Diagnostic Centre. I think it is recognised that car parking, particularly at the Royal Stoke site, is is an ongoing challenge. So us being able to provide those services off that acute site is and the access to it, I think, was one of the major drivers of being able to establish that offering where we've located it. So thank you. I think in terms of patients leaving hospital, there's a couple of areas there. So it is true to say that we still experience a higher volume of patients than we would like who are medically fit for discharge but remain on the acute site. Sometimes that's just about the complexity of their onward care arrangements and how best that can be coordinated and commissioned. Sometimes it is just because there is a need for better and improved collaboration between system partners. And I know through the work that we do through, say, integrated discharge facilitators, through the collaboration and the partnership working with colleagues at MPFT, that we're continually looking to review and improve those services. I think levels of, I'll stand corrected, but our levels of patients who are medically fit for discharge have reduced over time, but that's not to say there isn't work to still be done.
Thank you. Councillor Greatrek.
Thank you, Chairman. I know, Chris, you were here for the previous item, so I'm not going to labour the points too much, but the same principles apply, that this document talks well about the 5-year plan and achieving certain objectives like planning for break-even, having that achieved by 5 years, achieving all the KPI targets, and reducing the workforce, particularly bank and agency. And obviously some of those are contrary movements, you know, cutting costs at the same time as trying to achieve targets is difficult. There is actually a bit more detail, to be fair, in this document. You've got our page 33 that talks about the strategic programmes, the Brilliant Basics, Digital Enabled Care, Future Hospital, Partnerships and Collaboration, Financial Sustainability. I have the same comment though. How are those all going to be time planned? Because you can't do them all at the same time. It's all very well saying all the targets will improve over the 5 years and the costs will all be cut over the 5 years. But there has to be something happen first, and there has to be a schematic like a Gantt chart that says this is possible in year 1, this is year 2 and so forth. We haven't got that information. And just as a minor question, there's a reference also to a virtual ward. It's on our page 35. And I just wonder what a virtual ward is in relation to whether it's just somebody at home with a screen or if there is something different.
Yes, so thank you for the feedback around the report. I think you're absolutely right. There's a level of detail that sits beneath this, and there is a challenge to us in being able to coordinate appropriately and sequentially the different actions that need to take place for us to manage that change in as an effective way. What I can say is that internally we have a strategic programmes executive committee that does exactly that job. It takes over strategic oversight of each of those 4 elements and receives updates on the detailed planning and what we call the contingent interdependency. So what needs to happen first in order for something else to happen later down the line. And there's a particular emphasis there around our Brilliant Basics, because we need to just get some of our core services better and improved before we can start talking about transformation. So outpatients is a really good example of that. Over years, as new outpatient services have been developed, the way in which some of those clinics is running is different depending on what specialty or what outpatient clinic it is. So the first job we need to do is kind of standardise and harmonise the way in which those clinics are run before you can then transform them into something different. So there is that level of detail that sits beneath there, and as I say, there is I would like to say, appropriate governance arrangements that oversee them. The specific comment then around the virtual ward is that it's essentially patients who are managed outside of the acute hospital environment, often at home, but still with access to consultant level care and nurse level care.
As a follow-up, I mean, I hope you've got the continuity of people involved. You mentioned the internal agency that will monitor the performances. My knowledge about the NHS is it's never moving beast, and people move on and things change. People lose interest in original plans. So during the 5 years, is there some form of holding to the core with that group?
Yes, indeed. So the annual, the 5-year plan requirement has, so this will be the same for every NHS organisation. So whilst it's a 5-year delivery plan, they're called slightly different things. So it's a strategic commissioning plan for the ICB. It's an integrated delivery plan for the for NHS providers. So whilst it's got a 5-year timeline horizon, there is a requirement to refresh it on an annual basis, which will do part of the backward look to say, so what have we achieved in that particular year? What do we then need to achieve in future years? And that'll be an opportunity then for any kind of alteration or amendment, depending on any kind of changes that are required.
Okay, thank you. Councillor Norman.
I sort of apologise for this question, but do you remember coming to Burntwood, to Lichfield District Scrutiny Committee to talk about the Burntwood Health Centre?
In a previous role for a previous organisation, but yes, I do.
I'm just wondering about having confidence in the report here, because 2 years later, the ICB representatives we had at the Scrutiny Committee talking about the long-awaited Burntwood Health Centre said we should, you should not have said any of those things. You should not have promised it would be open by the end of October 2025. So my question to you, and I'm sorry about this, Chris, but what confidence have we in this report because of what they said?
Well, as I say, it was a previous role in a previous organisation, so I'm not sure I'm best placed to offer a view on what subsequent colleagues may or may not have said around my contribution at that point. I don't think that's appropriate for me to give a view on, having not been in that organisation and not been on part of those conversations for the best part of two years or so. What I can say is at the time that every statement that we made was linked to a report and an established programme. I mean, I take the point around the delivery of this report. I think we've included in the report some of the challenges that we expect to be able to have to navigate over the 5-year period. I think I'd go back to my response to the previous councillor around some of the governance oversight arrangements we have in place. And the fact that this is a programme that's been signed off by the board and therefore has trust board level oversight, so that the appropriate governance arrangements, I would say, are in place.
Can I just say that it's to do with the reports that we've been given today? If there's been any previous reports in any separate organisations, can we keep that to, I don't know, maybe if you email them, in regards to that. However, this is about today's report. So if you have any questions, please make sure it's about today's report. Thank you. Any other questions? Mr. Bass.
A couple of things. I know you've had considerable problems with freeing up ambulances and so on. I noticed I had a report from West Midlands Ambulance the other day that in April they had the fastest Category 2 response times of any ambulance service in the country, although they were still had the highest number of hospital delays in terms of discharge. I know you're doing quite a bit of work with the ambulance service. I mean, I did a visit to Stafford A&E a few weeks ago, and all the patients there said they'd all been picked up by an ambulance within an hour, and none of them had to wait to get into the hospital, and they all seemed satisfied with what they were receiving. And I know that, I mean, UHNM, Royal Stoke, has a massive catchment area, doesn't it, for particularly for major trauma. And as I understand it, you've got one of the best outcomes in the country in terms of the work that your major trauma team turn around. The robotics is really good to hear. And have I read somewhere in the report that you're tending to sort out electives more going to Stafford to make sure that electives get done, particularly in the winter? I mean, this has happened at Burton and it's been sorted at Derby, I think, and across some of the other hospitals. By separating out the electives from the emergencies, you don't end up in the situation where all the beds are full of medical outliers and operations get cancelled, etc. So I think that's quite positive. And then one other question that we've had come in from the public quite often is, it's good news that you're getting your diagnostic tests, but how long is it taking to get the results back afterwards? I mean, we've had somebody the other day was saying, I was told 2 weeks by the hospital. The GP says you'd be lucky to get them in 8. So, you know, behind the scenes of all this new equipment, have you got the radiologists and reporting people that can keep up with the demand that's coming through the door?
I think in response to Councillor Wallins, we've agreed to bring a subsequent report on the Community Diagnostic Centre. More than happy to include kind of diagnostic imaging times as part of that.
Thank you. Councillor Luca.
Okay. Good morning. My question is, you state that you're going to cut bank and agencies, but obviously, you're already relying on them quite heavily for the dropout of staff. So how are you going to make these cuts? Because I actually know from talking to people that a lot of the nurses now have worked out that if they swap over to agency, they make more money. So, I mean, how are you going to manage this? Because I can't see how you're going to cut bank staff and agency staff when you're already relying on them quite heavily.
Thank you for the question. It's certainly the case that we do use bank and agency staff as part of the National Medium-Term Plan. So this is the same for all NHS provider organisations. There is a year-on-year, there is a requirement to reduce year-on-year our use of bank and agency staff, in part because of the premise of your question, which is it's more expensive than substantive staff. So as with other NHS trusts, there is a programme that we're going through now that looks at the number of people that we need in order to provide the services that we provide, the skill mix that we need to maintain those services, bearing in mind developments in technology, etc., linked to our service redesign and productivity programmes. There's mechanisms then around how we coordinate job planning for medics. There's programmes around how we improve our levels of sickness, so that we've got more of our people in work more often. And then there is, on occasion, where we're able to substantiate and evidence that we're using bank and agency above the establishment levels because there has just been a sustained increase in demand above the above anticipated level. There is an option for us to substantially recruit to those posts. So there's 4 or 5 different measures that we're bringing into that particular programme. But you're right to say that it's a challenge.
Thank you. Do we have any more questions? Councillor Wallins.
Thank you, Chair. And just to follow on from what Councillor Luca just asked, given that the fact you're looking to offload a lot of agency staff, would you seek to get them on a permanent employment or contract, or would you just offload them as a whole and create that deficit?
So that'll be part of the programme that I've just outlined in response to Councillor Luca. We are, I think as the Councillor rightly suggested, a number of our substantive colleagues are often on the bank as well. So that wouldn't be a case of offloading people, to use that language. It's about how do we offer them more certainty through the established roles that we have. There will have to be a whole time equivalent reduction, though, in the rates of agency staff if we and other NHS organisations are to achieve the national planning requirement. I think I'm right in saying the national requirement over the next few years is essentially to eradicate agency usage. So there will be a reduced level of agency staff over that period to correspondingly to achieve the target.
Thank you.
Councillor Griffith.
Thank you, Chair. I'd just like to hear a bit more about this robotic-assisted surgery. It sounds very exciting, and with advances at technology at the moment, I would just wonder, do you envisage a day where it won't be robot-assisted? It'll just be the robot does it?
So UHNM have got one of the highest levels of robotic assisted surgery in Europe, actually. I can't quite remember the exact figures, so forgive me. It's probably better if I answer that through correspondence with Zach, just to make sure that we get that correct. But yes, as I say, we've been fortunate in recent times to receive a £12 million investment from the Denise Coates Foundation that will enable us to expand the number of robots that we have from the current 2 or 3 to 4 or 5. I think just given the complexity of the service area, it's better that we just take that away and come back with a more detailed response. I'm slightly apprehensive that in my eagerness to give you a response that I stray into areas that's not my area of expertise. So better that I follow that up with Zach, if that's okay.
Thank you. Councillor Luca.
I was sitting here and my colleague was talking about, the robotic surgery, what backups do we actually have if the system goes down actually while an operation's actually being carried out?
So I think in my response, I suggested that it's not my area of expertise. So I think we'll incorporate that into the update that we provide, if that's okay.
Thank you. Does anyone have any more questions? Okay, that's excellent. So thank you for coming and visiting us. I think next up we've got North Staffordshire Combined Healthcare, and we've got Ben Richards and Laura Smith to speak to us today. Oh, is it just Laura today? Okay, sorry. Laura.
Thank you. Good morning, everyone. Yes, I'm Laura Smith. I'm Deputy Chief Strategy Officer at the Trust, and obviously here today to talk to you about our 5-year integrated delivery plan. Within the papers, we've shared a summary of the plan and also highlighted some of the opportunities and areas of risk and challenge which we've identified. I think, as Chris alluded to, the plan was produced earlier this year, linked to the NHS medium-term planning framework, and sets out at a high level how we intend to develop and deliver our services between now and 2031. Central to the plan is how we respond to what we're seeing across the system, which, as all of you will be aware, is growing demand, increasing complexity, and obviously those expectations that are there for the communities that we serve about the services that they want to receive. So managing that against the need to ensure our services remain safe and that the quality is there and that they're sustainable into the long term. The plan does note that we start from a position of relative strength, so we've got a strong financial track record over the last 25 plus years, and also a strong record in terms of performance. And it's how we really move that forward then into the future, with that focus around the 3 shifts that have been set out by central government. The 3 shifts are reflected in the priorities that we've set within our plan and include expanding support for children and young people, developing neighbourhood mental health services, and also introducing a new electronic patient record to help support more joined-up care. The plan does provide more detail about what needs to happen in the next 1 or 2 years, so continuing to improve access and flow, reducing inappropriate out-of-area placements, and also tackling long waits, particularly for neurodevelopmental services, which I know have already been highlighted within this meeting. Beyond that, obviously, I think, again, Chris just alluded to, there will be an annual refresh, so we can be clearer on the priorities for year 1 and year 2, but we'll need to look at that in each of the subsequent years, taking us through those 5 years. And we have tried to be realistic about the challenges that we face in achieving our aspirations. So demand, as I said, does continue to rise, particularly in crisis care and for children and young people. And much of what we're seeking to achieve does depend on the partnerships that we have across the system and making sure those are developed effectively and sustained. Essentially, I think the key messages from the plan is that we recognise that doing more of the same won't be enough. If we need to keep improving outcomes and experience, then we need to shift towards earlier intervention and more joined-up care. So the intention for the plan was to balance that ambition with a level of realism, but I'm happy to take any questions on the content of the plan.
Councillor Wally.
Thank you, Chair, and thank you for the report as well. I just got one question in relation to the out-of-areas placements. As stated on page 54 of the report, it says there's a continued downward trajectory of adults in out-of-area placements from 89 in 2021 down to 33 in December 2025. I was wondering what more can be done to significantly reduce the out-of-area placements.
So that statistic that you mentioned is specifically relating to our mental health rehabilitation placements. So we have 2 sort of categories when we talk about the out of areas. So that is one of them, and that's our complex care team. So they have worked over a number of years to be able to bring people back into the area. We also have a priority around our acute mental health services. So those that will be generally shorter stay in duration and out-of-area placements in that respect. So the first one, in terms of the rehabilitation services, that is a significant achievement that's happened in terms of reducing those 86 to 33. And the team continues to really work. Again, it's working in partnership, so it's working with social care, it's working with housing providers, with employment organisations to ensure that people can be supported to return back to their local community. And that is an ongoing process. With the acute out-of-area placements, we have, after a number of years with none, over the last sort of 18 months or so, we have had a spike. The teams have, and again, across multi-agency partners, have worked really hard on that. So we're back down to, I think it was around 2 or 3 was the most recent number. So we have seen positive progress, and it's gone in the direction that we wanted to. So just need to continue to sustain that.
Just a follow-up question on that, but yeah, thank you for answering my question. In terms of out-of-area placements, for example, if someone from Lichfield is as part of the level 2 rehabilitation setting, where would they go, and what's the radius? For example, is it like a 25-mile radius, 10 mile, and so forth?
Yeah, so the intention would always be to keep them as close to home as possible based on bed availability and also the quality of that provider. So we'd want to ensure they were in a good or outstanding provision, and that's how decisions are made. So there can be placements sort of beyond that radius, so 25, 50 miles. We do have the data on that, but it is always as close to home as possible because we recognise the importance of that for the patient.
Thank you. Can we request the data? Cheers, thank you.
Thank you, Councillor Wallins. Councillor Greatrex.
Thank you, Madam Chairman. I know that, Laura, you'll have seen the 2 previous presentations, so you probably guess some of the questions I'm going to ask. There's detail here in terms of what's likely to happen. There's a column on our page 67 and 68. In your document, it's page 18 and 19, which is the top-level key movements, and there's a what will change column. There's also the focus, our page 78, 79, it's 29, 30 in your document. Both of those refer to things that will change and quite specific. But again, is there somebody keeping a Gantt chart or a time plan that says what will happen in which order? Because they can't all happen at once. And secondly, it's a bit related to that, the staffing high-level plan, which is our page 92, it's page 43 in your document, does go into quite some detail for 2 years at least, indicating by function where numbers are going to change. So given that that information is available, is that going to cause any problem that people can guess what is likely to be changing, given that some of this might be confidential?
Yeah, so in terms of the first question around obviously the Gantt charts or the project planning, so our plan mentions sort of our transformation approach, which is around the 4 different portfolios. So that's been something we've been mobilising since last year, and within each of those portfolios there is a sort of detailed delivery plan. Obviously some of these are newer schemes that are coming, you know, that are in development. The neighbourhood models of working is obviously a new initiative for us. So the details for each of those plans is building at the moment, but a key aim behind that approach that we've taken is to be able to do that sequencing and prioritisation, recognising that we can't do everything at once, and it's about understanding those interdependencies. So there is definitely a level of detail that sits behind that. There's monthly meetings for each portfolio, and there's project groups obviously within that. So those Gantt charts and that reporting is there. In terms of the workforce plan, there's nothing, you know, we have had, trusts weren't mandated to publish their delivery plans. So although we haven't formally put it on our website, we were happy for it to be shared in public in terms of the content of the paper. The workforce plan for the 2 years was based on some of the more certain elements that were known in terms of potentially some of the new investments that we were getting in. So rollout of mental health support teams in schools. So we knew some staffing changes would arise due to that. But recognising a level of uncertainty as well in terms of, I've mentioned the neighbourhood models of care, so actually we don't fully know yet what that workforce profile will look like and where the changes will come in, so that will be a key part of the sort of annual refresh and month to month as well, planning for us, you know, as we work through that.
Have the follow-up then, is it evenly tempered across the 5 years then? Because obviously the information we've got for the first couple of years indicates that some changes in numbers are going to happen. But do you feel that the 5-year plan's achievable across the length of the project timescale?
Yeah, I mean, I think we always knew that 5 years was a challenging ask. We were asked to work at pace after the medium-term planning framework was published nationally, and the 10-year plan still been evolving as well in terms of some of that detail. So what we set out was kind of, I think, as much as we could with, you know, the level of confidence that we could have at the time, but we always recognised that it would be a case of needing to review year on year where we were and sort of change what we needed to accordingly. So the plan is really setting out our aspirations, what we think we can deliver, but there are lots of caveats to that and risks that we've highlighted within it as well.
Okay, thank you. Councillor Edgeler.
Thank you very much, Chairman, and thank you for your presentation. Right, you say neighbourhood mental health centres in 2028-29. Where are they going to be situated, please? That's my first question. And on page 87, your page 38, reducing wait time for children, you know, with the mental health problems and that, how are you going to achieve that? Because this is something that is so important. And it's, you know, we're talking not weeks, we're talking years sometimes for them to get help. So really a lot of work needs to be done on that situation. You've probably followed that up from the previous questions and from the last presentations. And all right, can I just ask also how the new centre is going at Midland Partnership with the people that's coming in with mental health problems in police custody? I'm just interested to know how successful it is, because it's been open now for about 12 months. Thank you.
Yeah, I'll just, so picking up that last point, so with that being Midland Partnership, I think Jenny and Colin will be able to speak to that on the next item. For the neighbourhood mental health centres, the requirement nationally was to have one in each place, as it was labelled, by 28-29, so that was one for Stoke and one for Staffordshire. So again, MPFT are leading on the Staffordshire site, so we'll be able to talk to that. From a Stoke perspective, we're combined as leading that one, and we're looking at the centre at the moment, likely to be within Hanley area. For the children and young people, yeah, absolutely. The weights, obviously, and there's various weights I think we're talking within there. So we've obviously got our core CAM service where we've got weights, and then the neurodevelopmental services where we've talked about ASD and ADHD as well. I think, I mean, and don't quote me on this specifically, but I think there's a figure of something like it's a 900% increase we've seen since COVID in terms of demand for those services. So there's lots of work that's been underway for a number of years about reducing that. So we have seen the rollout of the mental health support teams in school, and that continues to happen. So as part of the latest wave, Staffordshire Moorlands will see a rollout of mental health support teams, which has just been approved. That will hopefully help to pick up on some of those earlier needs. There's lots of work that's happened within our CAMS teams to sort of streamline the pathways so that we move through children and young people through as quickly as possible while still getting the care that they require. I think I'd referenced in the report that our North Stoke CAMS team have recently piloted 8 till 8 working, having previously been a 9 to 5 service. That's gone really well, and our other 2 CAMS teams, including North Staffordshire CAMS, are due to roll that out. That's helped with reducing, with improving attendance at appointments, so it means we can see more children. It's the feedback from children and families has been really positive on that. Another element which we've been looking at is really in terms of the shift around treatment to prevention and hospital to community. So last year we invested around £270,000 in voluntary community sector grants around children and young people. And we've been working with, there was 15 organisations awarded funding through that. And we've been working as part, establish a community of practice really to bring our teams together with those voluntary community sector providers. It's not closed to those 15 providers that receive funding. We're trying to build it as we go. And it's really looking at actually how do we share our specialism that we have, but enable children to be supported in their communities at an earlier stage. How do we look at the skills and training needs of individuals working in the sector. So that again is a long-term piece of work, and we hope to evolve it as neighbourhoods develop, and looking at waiting list management within that as well. So actually, you know, if we have got children and young people waiting to be seen, can we ensure that they're linked into some form of suitable provision that's, you know, supporting them while they wait. So
Thank you, Chairman. Thank you for that. But do we have a look at, you're talking about children and young people, do you have a look at the nursery situation where children in nursery are playing systems where they're probably suffering from and showing signs, you know, and I'm thinking about, you know, 2-3-year-olds, you know, where they're showing signs of problems, if you like. Do we think of doing any work with those areas? Thank you.
yes, so I think members may be aware of likely to be aware of the Best Start family hubs, obviously that are now being sort of established across the county. We are linked in, our CAMS teams have been linked in. We kind of had one of a series of meetings a few weeks ago to look at how we work as part of that early years agenda. So there is some work that happens at the moment within teams, but it's how, again, we strengthen that within communities through the Best Start family hubs for the 0 to 5 age range.
Thank you. Is there any more questions? Councillor Luca.
Okay. Thank you for this report. Could I just ask, where you say you're going to accelerate from hospital to neighbourhood, what is actually going to make sure that you don't actually accelerate it to the point where it starts affecting quality of care, and obviously you're missing actually opportunities to actually help and make the service better?
Sorry, can I just ask you to clarify? So, sorry, that in having the neighbourhood centres, that all our effort isn't focused on developing those neighbourhoods, and we're missing...
Okay, in the report you say that the Trust will accelerate the shift from hospital-based care to community and neighbourhood delivery. Now, obviously, if you're going to accelerate it, what are you going to put in place to make sure that it's not going to affect the quality of care given while you actually are transferring this over? And obviously, if you accelerate it far too far, you're going to miss opportunities to actually be able to provide a good service.
Yeah. So at the moment, as you know, the design, I said, of the neighbourhoods and neighbourhood mental health centres in its early stages, but our business as usual operations are continuing unchanged. So its roles, kind of such as mine that isn't clinical frontline, is doing that partnership work, kind of in the background, sort of building those relationships, looking at the design. We're looking at co-production with local communities at the moment to get their input into what they want to see. I think we're quite clear that this, for us, neighbourhood centres aren't trying to replace secondary care, that needs to remain, but actually there's an opportunity to bring better access, and you know, it's that walk-in model that I think is at the heart of it, and that people then can get to signposted or linked into the correct service, and if that's secondary care, that's the appropriate service, and that will remain unchanged. You know, we don't know further down the line what we might see. I know the hope is that we see that shift and we see less demand on secondary care in the future, in which case our services might be configured differently, but that's certainly not the case at the moment. So we are very much maintaining our focus on our current delivery, but hoping to work really well with partners to develop these new models.
Okay, also third parties that you're going to be working with, what safeguards are you going to put in place to make sure that they actually are carrying out what they're supposed to do and not actually going out of their, how can you put it, their delegated power, which could actually cause, obviously, issues in the future?
So in terms of third parties, I guess, again, from a neighbourhoods perspective, we're thinking about sort of trusted voluntary community sector organisations. If we were to enter sort of any formal partnership or commissioning arrangements, obviously that would be subject to all the due diligence that normally happens around that. So all of those safeguards would be in place. We're not proposing at the moment to change clinical models and say you are now delivering this care that was previously delivered. You know, we're still subject to regulation, and you know, pathways may adapt over time, but we would ensure that those are designed with clinicians and with the appropriate governance, so that we're not, you know, asking people to do things they're not qualified for or, you know, regulated to undertake.
Okay for that, but what would you actually say is the governance?
The governance, so again, the governance is just establishing at the moment, but it is linked to, at a high level, from the Health and Wellbeing Board at the top. The place boards are in the process of being established, and we would see our you know, the development of our neighbourhood mental health centres reporting into those place boards. So that would be where the assurance comes through, as well as with the regulator as well, CQC.
Thank you. Councillor Norman.
Thank you, Chair. It's not a big deal question, but I presume the abbreviation OAP does refer to old age pensioners.
Out of area placements.
Thank God for that.
Sorry.
I actually have a question myself. In regards to care in the community and the surrounding residents, what assurances are you going to give to the Staffordshire people that when you're putting people into specifically living facilities, what assurances are you going to give them that that won't affect their everyday life? And in regards to any sort of something that I'm dealing with at the moment, without going into too much detail, noise or disturbance due to, obviously, unfortunately, people's disability or mental health. How are you going to assure the Staffordshire residents that that isn't going to affect them in the wider scope for years to come? after you put these facilities in their areas?
Yeah, I mean, I think the only thing we're proposing to create is the neighbourhood mental health centres. You know, we're not proposing other facilities apart from that. So I suppose on the neighbourhood mental health centres, we are still, as I say, scoping sort of locations. At the moment, so Colin and Jenny can again probably speak to Staffordshire, because at the moment we're talking with Stoke about the Stoke Centre. We will be responsible for the North Staffordshire sites, but we are looking at existing NHS and local authority estate in terms of where those services operate from. So it won't be entirely new in terms of people using, you know, people coming to that facility or estate who have health needs, who have mental health needs. And it will go back again, I think, when we talk about co-production. You know, we're wanting to kind of be out in the communities when we're designing the centre, and that will be with local residents as well, who may or may not have a mental health need, and really just use that as an opportunity to address any concerns early on. And I think with anything like this, it's always just about the relationship. So it's about having dedicated points of contact, so that if people have got concerns, they can raise them, and working collaboratively, I think, just to address anything at an early stage, but ensuring that we have, you know, that our patients and people who access services are supported effectively, and hopefully reducing those concerns.
Thank you very much. Is there any more questions? Councillor Luca.
Yeah, just reading on as well. In the mental health, you say that you want to actually expand like the self-service and self-help. How are you going to actually get around the problem that a lot of people with mental health actually they try to hide it? So how are you going to get them to come out and actually try and help themselves? And obviously when you shift this from hospital-based to community-based?
Yeah, I mean, there's quite a lot in there, I suppose, in terms of so the accessibility is one thing. So, you know, in terms of if you were mentioning stigma or people having those concerns, so providing a range of options, I think. So we've got within Combined, we have our wellbeing portal, which allows self-referral and also provides kind of signposting and information. I think it's then working through those trusted community partners. It's about who people feel confident in speaking to, and then how they're supported once they've, you know, if they do need help. And also with carers as well, I think that's the other, you know, another key focus is working with family members and carers to ensure that, you know, they are supported and then can be supported with the person that they're caring for to access support in the way that's most appropriate for them. But it is an ongoing challenge, but I think the multiple solutions, multiple points of contact.
And just one follow-on from that. Say you've got the person who's now actually done the self-referral. What is going to be the time period from referral to actually first appointment?
Yeah, so it will vary depending on services. A lot of our kind of performance metrics focus on a sort of 4-week referral to assessment time period. So that's where we would aim for the majority to have an assessment within the 4 weeks, and then go on to, you know, an appropriate form of treatment.
That's quite concerning when somebody actually with a mental health issue would obviously need the help there and then, and they've got to wait 4 weeks to actually get any type of help. I'd be quite concerned there.
It would obviously depend on the service and the level, I suppose, of risk attached to that. So if it was a crisis presentation, you know, that would obviously not be a 4-week. We're talking sort of 24, 48, 72 hours, and making sure, you know, appropriate safeguards are in place. So it will be different depending on specific service. And if you did want any kind of further information on that in terms of the metrics that we use, we can provide that.
Okay, Councillor Mansfield.
Thank you, Chair, and thank you for the report. I wonder if I could ask a question about the workforce plan, which is on page 43 in your report. Just to check I've understood it properly before I ask the question. The establishment column, is that what we expect the need to be in those categories? So we think we need this many posts, and staffing posts is how much we've got or we expect to have. Thank you. There are a couple of categories where we've got some decent gaps. So I think it's registered ST&T, which again, sorry, I don't know what that category is, but we've got a gap of 125 in 29 between establishment and staffing post. I guess, are we happy that we can live with those gaps, that they're manageable and they won't cause repercussions for care?
Yeah, I might need to take any specific questions about those back to, you know, to our people team who developed the workforce plan. But I think, you know, through the trust, the processes that we have in place in terms of our risk assessment, quality impact assessments, you know, we're constantly looking at our workforce and ensuring that we've got safe levels, you know, safe staffing levels where they're required, and that we're managing any gaps in staffing as needed. So we do have very low vacancy levels at the moment, which is, you know, really positive. So the lowest they've been for a long time, but anything on specific categories of staff I would need to take back and get a response for you.
Thank you, that's really helpful. I guess the point of my question is thinking about Councillor Greatrex's comments about the kind of contrasting forces. If we've got areas where we have workforce gaps and we're trying to reduce agency and bank, it feels like something that could possibly pull against each other. But I appreciate the specifics aren't going to come from yourself.
No, it's fine. And I think sort of Chris again sort of spoke to some of the challenges of that. You know, we've had the national directive around agency and bank, and we are doing the work that we can to reduce that. Patient safety, patient care does always come first. So, you know, we will, where we have higher levels of need and acuity, we do still use bank if we need to. So it is that balancing act. But it's a challenge.
Okay, Mr. Bassett.
You touched briefly on the voluntary on the voluntaries sector, and this applies right across the county. In recent years, and we've been looking at this from Health Watch quite extensively in the last year or so, and I've been out to 40 different voluntary organisations talking to them about the support that they're giving to people with mental health needs. And both the trusts are funding things. For example, in Tamworth, there's a crisis cafe that's open every night in the week, Saturdays and Sundays. It's open till 11 o'clock at night. And staff have been known to be there till 2 or 3 o'clock in the morning before now, and it's on the main shopping street, and it's seeing somewhere around 400 people a month, and anybody can just drop in the door. So those sorts of services are increasing, and drugs and alcohol, particularly organisations like Better Way Recovery that are user experience led, are increasingly contributing to supporting more and more people in the community. And I think the feedback we're also getting is that people's problems are getting more and more complex as well, so that when they do get into services, they're taking longer to process. But we've been looking at what people do once they leave mental health services, and there is a whole myriad of things out there for people to support people now, and that's growing. And I think both the trusts have been supporting those organisations like Burton Mind and Wellies and all sorts of people around and about. They're doing quite extraordinary things with people.
Yeah,
and it's effective.
Yeah.
And the feedback from the people who use it is really good. Yeah.
Yeah. And I don't think there was a question there, was there? But was there a question there? Was it? No, that's fine. I was just double checking. But no, yeah, I absolutely agree.
From a patient perspective, we hear these things all the time, and I think it's important that, for balance, we give some views that we're hearing from patients, that you guys are funding services out there in the voluntary sector that are really effective.
Yeah, thank you.
Okay, thank you. Is there any more questions? Okay, thank you for your report. We do request to receive further data in your out-of-area placements, if that's okay, and that which is where the patients were placed and what you were doing to reduce the number of these placements. Thank you. Okay, so next is the MPFT. Report of the Midlands Partnership, and it's Jenny Collier, not Janny, as it says on the... Thank you, and welcome.
Thank you, Chair. So yes, Jenny Collier, I'm Managing Director for Services across Staffordshire and Stoke-on-Trent Midlands Partnership Foundation Trust. And I'm joined with by Colin Anderson, who's our Deputy Director of Strategy, and was very instrumental in pulling together the plan that you have in front of you. So we were just going to start by talking through kind of the principles behind the plan, touching on some of the things that I know you've already asked questions about, and then obviously taking any questions.
Yeah. Okay, no, thank you for that. So yes, the report attached is a summary of our 5-year delivery plan, which does contain some further details. But as I said, we've kind of summarised the key elements from that plan. We've set out in the plan our broad challenges as an organisation. Those are very consistent with our colleagues, other providers, and of course challenges we're all facing in terms of demand on our services, financial pressures, workforce pressures, and demographic changes, of course, as well, which is impacting on how we're providing our services and how we're potentially going to be providing those going forwards. In terms of our approach, so we've kind of set out our broad approach as an organisation. It's kind of 5 broad principles. The first of those is very much around us as a system partner. So you'll see through the report a real consistency, hopefully, around our plans to work in partnership and to be more collaborative, and how we can develop working in partnership and further around that sort of provider collaboration, etc. So this is about us positioning ourselves as a proactive partner across neighbourhoods, places, and the emerging cluster. So as Staffordshire ICB works more closely with Shropshire, Telford and Wrekin, that's quite is an interesting development for us. The second core area then is around the neighbourhood-led transformation. So I know we've heard a lot around neighbourhood health, but again, that's us prioritising neighbourhood health to reduce urgent and emergency care demand. And again, delivering the 3 shifts that are set out very clearly in the 10-year NHS plan. Also, it's very much about us strengthening our primary community care resilience. That's is a key underlying factor, and as I've mentioned before, about stronger partnerships and growing those partnerships. And we specifically made reference to that in our report, particularly around, what can we do in terms of those high-performing opportunities for collaboration with Staffordshire County Council and our local authorities and voluntary sector partners too, as well as our ICB provider partners. So that's a key theme that we've set out, as well as our mental health leadership is key for us. So that's about us enhancing our cluster-wide leadership across secondary mental health services, optimising inpatient provision, and then that left shift to community care, again, is absolutely crucial. So that's very much about us scaling our frailty, long-term conditions, and subacute community models. Ultimately, again, it's about how we can release hospital capacity and help to improve that system flow. So those are the 5 kind of broad principles that we've kind of set out really at the front end of our report. Thank you. Yep.
Thank you. So in the report, you'll find details of the financial plan, which I wasn't going to go into detail on that, given I know you've already had opportunities to scrutinise that, but that does include a £29 million recurrent efficiency saving. We are on track in terms of the delivery of that in our financial performance as it stands this year. The report outlines the operational performance that we are expected to achieve in line with NHS operating requirements, so particular focus on our waiting list across community services, so achieving 92% being seen within 18 weeks. So again, we are on track to deliver that, although we do have pressures in some services such as our MSK services. Talking therapies, again, has got some clear targets set against it. We do tend to perform quite strongly in terms of our delivery of talking therapies compared to other parts of the region, but I know you've touched on that earlier in terms of requesting a more detailed briefing. And again, the other areas are linked to mental health, so the out-of-area placements that you've already queried in relation to North Staff's combined healthcare, and then particularly, as you referenced, the waiting times for children's services, particularly CAM services. We've set out a trajectory with the ICB to eliminate any 104-week waits by the end of this financial year. So the key areas of focus for the next 5 years are, again, the hospital to community programme, as Colin touched on, so really that shift from secondary care into community primary care and the wider community offer. We will, over this winter, be looking at developing some models with UHNM in terms of alternatives, particularly around frailty, so an integrated offer across ourselves and UHNM around frailty. Neighbourhood health, as we've touched on, will be a key area of development. So we know at the moment that our services are fragmented, that generally the feedback we get is that people receive good care, but that care is in silos, so not necessarily coordinated. So the focus will be for neighbourhoods is about how we better coordinate that care and get upstream in terms of people's needs. So rather than waiting for crisis to hit, we're doing that work with people, that care planning earlier on. We have clear plans in terms of if people do deteriorate, how we wrap services around them in the community. Again, you've touched on discharge from hospital and particularly intermediate care services. So we've done a huge amount of work over the last 5 to 6 years around discharge services. So they do perform well, but we know we could maximise that offer much more across intermediate care as what's termed step-up activity. So how we avoid people getting from hospital into hospital in the first place. So we went live 18 months ago with an integrated care coordination centre for urgent care. So that's effectively a facility where we coordinate any urgent care needs that somebody may have in the community. So we pick up any activity coming through West Midlands Ambulance Services that's categorised as a Cat 3 call, and also call before convey. So if an ambulance attends a patient, determines that actually their needs could be met with the community, within the community, they ring the ICC and we coordinate that care and will facilitate access into things like our 2-hour community response services, virtual wards. But we know there's further that we can go with meeting the needs of that cohort of people in the community and utilising some of our intermediate care facilities, whether it's our community hospital beds or our home first services that go in to support people at home to be able to keep them at home. I mentioned the challenges we've got around community services. So MSK in particular is one of the areas where we're pressured in terms of meeting waiting time standards. So we're all working with community providers, voluntary sector, looking at actually self-managed care pathways in terms of how we can meet that demand for people earlier on and ensure we've got efficiency in terms of those services. We've also seen a huge growth in demand for our community nursing, also district nursing services in particular, so 30% increase since the start of COVID. We have modelled out the gap that we have in terms of meeting the demand coming through community nursing services and are working with the ICB in terms of the investment needed to address that gap. We are continuing to prioritise the people coming to those services so we can make sure their clinical needs are met, but we know actually that service isn't the holistic, proactive office that we necessarily want it to be going into the future. I've touched on children and young people's services, particularly mental health services and ADHD and autism, where we know we've got pressures across services in terms of being able to coordinate a Leeds and Ed service that's more responsive to local people's needs. From an adult mental health perspective, again, Laura's touched on a lot of the developments there, so how we reduce the out-of-area placement. So again, the offers we have in the community being more proactive in terms of picking up people before they're at risk of hospital admission. We are developing a 24/7 neighbourhood offer. For the first place will be Stafford in terms of location of that service. That's alongside things like the Crisis Cafe that you mentioned over in Tamworth. We've just gone live with the Crisis Cafe in Stafford, so expanding the offer that's available within the community and working very closely with the voluntary and community sector to deliver those offers. As part of all of that, we know one of the challenges for the NHS is how we move from treatment to prevention, so creating the capacity within our services to capture people upstream before they get to the point of crisis. So things like the neighbourhood offer, as we move to that, we know in areas like Birmingham where they're further ahead with their neighbourhood offer, actually they've seen a reduction in demand across services to enable us to create the capacity to provide more proactive care. So we have been testing some models for frailty where we go out and case find people who are at risk of deteriorating due to frailty and putting in a case management approach to effectively coordinate a whole range of services around them before they get at the point of becoming either moderately or severely frail. But again, we need to create the capacity for us to scale those services up across the county. Anything else you'd like to?
I think so. Yeah, it was just the last point. In essence, we've just concluded the report really by setting out our partnership as a key ambition. So we're currently resetting our organisational strategy based on what's been set through the 10-year health plan, our local priorities, as well as how we're going to deliver the national priorities. And we recognise we can't do that unless we're working in partnership, and collaboration is at the heart of that. So we've just kind of set out there just the importance of that and some of the key themes that Jenny's already talked about. For example, the prevention and integration agenda is absolutely huge. You know, we're emphasising prevention, early intervention and well-being. We talk a lot about integrated person-centred care. So again, that's about a greater integration across physical health, mental health, community, social care and children's services. We've talked a lot about the neighbourhood-based partnerships, but also, again, we've set out very clearly the alignment with local authorities, Staffordshire County Council, the local authorities, and being aligned in terms of delivering those ambitions and those priorities. We're not duplicating to a certain degree. What are the opportunities to work more collaboratively? And we've referenced the Staffordshire Health and Wellbeing Strategy as a really good example, which sets out very clearly vision for the future, and certainly in terms of our strategy refresh and reset, will very much align to the vision that you've set out in your health and wellbeing strategy. So that's really, yeah, that's it for me.
Thank you. Councillor Edgeler.
Thank you very much, Chairman, and thank you for your presentation and your report. Right, I've just got to say, first of all, thank you for all the good work that you do. I've been involved with Midland Partnership for a long, long time now, and I've seen it grown and grown. So I don't think the committee probably realise all the good work that goes on at St George's in all the different wards. You know, you've got a ward there that's building relationships, mothers and babies, where the mothers don't want their babies when they're born, and they work with them, and it's just absolutely phenomenal what you do, so thank you for that. I won't mention about mental health and children because you know how I feel about it and about the growing concerns we have about moving forward on that. But I also want to mention, and you will answer my question about the new centre, and I can't remember the name of it actually, where people go with, it's been picked up by the police.
Walton House.
Thank you. Thank you. Right, so you answered the question on that. But one thing I do find very strange that you've not mentioned in your report, and that's, and for the committee to note, that all the good work that you do with the prisons throughout the country, not just in Staffordshire. I think that's absolutely phenomenal, you know, because people enter prison with mental health problems and then they come out. So I would, if you could, give a little explanation to the committee about the work that you do with prison and the services that you offer. So thank you, Chair, and I'll leave it at that. Thank you. Oh, and where is the crisis cafe in Stafford? Thank you.
So the Crisis Cafe in Stafford is based at House of Bread, so we're working in partnership with the House of Bread and Turning Point to deliver that Crisis Cafe. Thank you, Councillor Edgeler, for your compliments. We do work with prisons up and down the country in terms of in-reach, and we have local relationships with Stafford, so we provide a whole range of mental health services into prison facilities, but also for Stafford we also have dementia services that in-reach into the prison facilities as well.
Thank you.
So Walton House is the Crisis Assessment Centre, so that's our facility that replaced the 136 suite on St George's Hospital. So it's a facility that the police can attend, but also the ambulance service are able to convey people that are in a mental health crisis. We work also with County Hospital in terms of pathways that when people are attending the hospital, being able to transfer them into the Crisis Assessment Suite at Walton House. The activity there hasn't been as high as we would necessarily expected when it went live, so we're doing work with partners in terms of increasing the level of activity coming through the Walton House, but along with the Crisis Cafe that we've got both in Stafford and Tamworth, gives us a real opportunity in terms of those people in mental health crisis having both informal access or access through other partner agencies for assessment and support.
Thank you. Councillor Norman.
Thank you. The question I've got is just about the sickness to prevention. We've prevention has been talked about for decades and has not been, well, doesn't seem to be dramatically improved. But your faith is in, I think, in the neighbourhood offer, neighbourhood. So is that the main tool you think will get improvement in prevention? And what if you can give me a couple of examples, illustrations of how it would work, you know, to a patient coming in there?
Yes, so I think there's multiple offers in terms of preventative care. So right from that, you know, your things like no smoking and all your campaigns in terms of earlier, but also how we become just more proactive in people that are known to services at the moment. So I think with the neighbourhood healthcare offer, there's a number of opportunities. Firstly is the working with voluntary and community sector agencies, and actually mental health are much more further forward on this than necessary physical health services. So looking at all of those factors that are wider determinants of health, so things like housing, employment, healthy lifestyle activities, social connections, mental health services are much more advanced in terms of that being an integrated mental health offer in the community. I think it's the same opportunities from a physical health perspective when we know actually 20% of our healthcare delivery is actually the thing that's going to impact on somebody's outcomes. It is those wider determinants of health that are going to have the greater impact, but also the work that we're doing at the moment around multidisciplinary team meetings in the community. So we're running those with primary care effectively as early implementer sites. So we've got that in East Staffordshire, Tamworth, Newcastle and Stoke, and we're seeing through there multiple opportunities where teams could have intervened earlier before somebody's got to crisis point. So at the moment it's about us working better together to be more efficient as a system, reduce the silos. That means that then we've got the capacity for people to be picking up people earlier and doing that work before they've got to crisis point. So it could be things like occupational therapy and equipment in the home, that quite often it's the point that people have got to crisis not necessarily knowing where to go. We could have been case finding those individuals that have potentially got care going on, thinking at some point that need for care is going to increase. There's an opportunity for us to wrap around from both a health and social care perspective to help plan for that and for it to be done more proactively rather than what we see at the moment is crisis response at the point that people's conditions have deteriorated and they can no longer cope at home.
Is it okay if I summarise it as basically listening to patients and having a holistic approach? If you want to use that phrase in your future reports, I don't mind.
Very much so. We talk about person-centred care, but that's the ethos of it, is sitting, listening to patients. We talk about what matters to them or what matters to me, and sometimes the focus can be about health and health outcomes. Sometimes that isn't what necessarily matters to the person. It might be their ability to get up and down the stairs, all of those sorts of things. So it very much being person-centred, as you say, listening to people in terms of what matters for them, both now and into the future, and us doing that advanced care planning in terms of responding to that.
I just wanted to come in there as well. I think kind of underpinning all of that is, so we've done a huge amount of work around population health management, so understanding our populations. So for example, you know, we've developed patient profiles now, so we can be much more targeted in our approach, so we can really, you know, identify where we have perhaps inequality in terms of access across different services, and we can use those profiles to really target specific cohorts, specific populations, patients, to really focus around that health inequality and how we can address that. So we've done a lot of work in terms of developing dashboards, which really helps to inform some of those big decisions that we need to do, or we need to make.
I think AI would obviously be a great help here on that aspect of it as well, the profiling and so on. No, that's great. I used to work for Age UK, Staffordshire, and you guys, so listening to older people is always the key thing. It was always the key thing for us, and they tend not to get listened to in the past. I think things have changed quite a bit, and no, that's great. You're thinking outside the box. So I might even use a cliche, but great. Thank you.
Does anyone else have any questions? Oh, Mr. Bassett.
Just following up on the population health management, I've been out to some of the events that your guys have been running around the country in conjunction with primary care networks, the BEAT events, which are screening, targeting people around heart disease and high blood pressure. In Burton, they did 900 and something people in a day. And there was one in Tamworth a few weeks ago where the police told them to close it down because the queues of cars trying to get into the car park was stretching back into town. So talking to some of the patients that had attended that, they were getting advice, they were getting screened, they were getting signposted to either pharmacies or back to their GPs, and they were told what to say to their GPs when they went back there, which gets past some of this issue about can't get an appointment because I don't know what to say to get an appointment. So, I mean, those events have been quite effective, I think, over the last few months, and it just shows that basically GPs can pick off from their practice register a list of patients that fit a certain criteria and then target them. And that's where analog to digital starting to show. But it was interesting, there was one guy there who actually worked for the NHS and didn't realise that he could see his GP notes on his NHS app. So I showed him how to do it, and there were 457 entries. So, you know, even people working in the NHS haven't learnt to use the NHS app properly yet, some of them anyway. That's just a comment, really.
Thank you. I mean, just thank you for highlighting those events, because we have run them right across the county, and I think we've been absolutely surprised by the level of attendance, and it is unfortunate that we've caused some traffic issues in some areas given the numbers, but I think just demonstrates the level of demand across the community in terms of being able to access some of that health advice and information. As you say, there's multiple people that we picked up through those events that we've either navigated into primary care, pharmacy, but also people that have gone straight to hospital, actually, where we've picked up some significant conditions that have needed that secondary care input. So we are continuing to do those and keen to explore them into other areas outside of heart failure, given the demand that we've seen from the community. And I think just demonstrates partnership working in practice, because that was very heavily done with the primary care networks in each of the local areas, local charities, voluntary community sector, as well as the clinical services that we've got across the county.
Thank you. Councillor Greatorex.
Thank you, Chairman. Jane, you'll realise that you've sat through 3 presentations, and I've got the same sort of comments as before. So I'll just say it very lightly. The 29 million of savings and break even by 26-27 are the aspirations. There's little in the way of detail of how they're going to be achieved. Although what you have got is you've presented today on 5 broad principles. But on page 108, you've got 6 core contractual priorities. And then if you go on to page 109, there are 10 areas of key areas of focus, which in turn contain 3 of the shifts. So your prevention, digital and community from hospital is 3 of the 10. That in itself might be a bit confusing to have that number of separate aspirations to achieve. But I'll park that for now. That's up to you to consider. Specifically on 710, there is some detail there on page 109 about reviewing services that cost more to deliver than funded and working with partners. You then go on in section 8 to talk about partnership working and working with local authorities, voluntary sector and communities. I wonder if you've had any barriers to working with those agencies before, or if that's something that you tend to investigate more. And secondly, your 7.10 refers to reducing underused, outdated spaces to improve more proactive care. And I wonder if that means closures of buildings or closures of units or reallocation of space to something else.
Okay, thank you. So just in terms of your initial comment around the finances, Faraz Patel, our Chief Finance Officer, has been around the financial elements, and there's a robust plan in terms of the transformation that sits behind the 29 million, and we are on track delivering those, hence the Trust is currently reporting financial balance, in fact a very slight surplus a year to date in terms of the financial position. You talked about the priorities, so the first section is around the commissioning priorities and then those that are linked to the 10-year plan. There is a lot that in there, but they do all overlap and connect together, and you know, as a big organisation, our ambition should be quite big in terms of what we want to achieve over the next 5 years in terms of our strategy and our operational delivery plans. You talked about the barriers in terms of partnership working. We've done a lot to invest in those relationships. So think particularly like the voluntary sector, community sector, we work really closely with the likes of Support Staffordshire around those relationships. Support Staffordshire were joint chair of our community mental health transformation programme, so absolute commitment for how we shift investment into the voluntary sector and community provision at a local level to be able to meet those needs. And we have the, you know, similar partnership arrangements in terms of that work with the local authorities, but also with us as partners across health. Can't say we always agree, you know, we do challenge each other, but actually that's one of the things I think as a system across Staffordshire and Stoke-on-Trent that we do work collaboratively and productively together and built some really strong relationships over the last 10 years. Oh, sorry, on the buildings, the estate. So that is part of our financial savings plan in terms of the number of buildings. So as a community provider, we're operating services from over 200 buildings across Staffordshire and Shropshire. That's a huge amount of buildings to service and not necessarily great accommodation for a lot of our services to be delivered in. So we are looking, linked to neighbourhoods, how we can consolidate services together and use some of the funding that's coming out nationally to invest in those buildings, given we know the quality of the accommodation that we're delivering quite a lot of our services is not to the standard that we would necessarily want it to be. So that is part of our strategy, estate strategy, is to try and consolidate into a smaller number of buildings that are more efficient. We're keen to do that again with partners, so it's a one-stop offer that if you're coming into that community facility, you're not just having access to one services, actually you've got a whole range of services available to you and much more community-led. We've just gone live, so the Hayward Outpatients building opened on the 20th of April. Again, that's a great community facility that's open to the residents across North Staffordshire. So we're looking at how we can maximise the space available to deliver a more integrated offer of care. Similarly to Leek Moorlands Hospital, that we had a whole range of services across Leek. We've consolidated that all into the community hospital. That means we've got better opportunities to integrate care. We do have more challenges in the south of the patch, so one of the things we're looking at is investment for areas like Cannock, where we've got disparate buildings and not necessarily a natural place for us to be able to co-locate our services together.
Okay, thank you. Does anyone have any more questions? Councillor Luca.
First of all, thank you for this report, and going back to some of the things you actually said in the report about when the patient's actually being released from hospital. That's just as bad as when people are first coming to the front door, because I've been there as an ambulance crew at the discharge lounge where either their paperwork isn't ready, their medication isn't ready, or their care plan. So that means that when we've actually been allocated the job, we get 15 minutes to complete the job in. If we don't actually able to actually complete that job in the 15 minutes, we then have to refuse the patient. And some of these patients, they're sitting in the discharge lounge for hours. I mean, so what are we actually going to do about that when it comes to actually the plan forward? And the other one is, obviously last year, without a bed, we, if I remember right, we budgeted for 5, but ended up using 20. So, moving forward, what actually is the plan for out-of-area beds? Because obviously, I mean, the estimates really is just nothing more than a guess of what we're going to need. So, how are you going to incorporate that into a budget?
Thank you. So that's the mental health out of area beds that you're talking about. Okay, so the first, in terms of discharge from hospital, we absolutely recognise that as one of the challenges, and Chris talked about the discharge facilitation arrangements. So MPFT coordinate a lot of the services outside of hospital, so things like Home First to support people being discharged home. We've been very successful with that, and the model we've got enables us to be able to get people home either same day or next day. For our beds, it's an average wait of 2.9 days for people to be discharged into a bed, and we do perform well compared to other parts of the country. Having said that, I would absolutely like that to be, again, same or next day in terms of enabling discharge. It is that piece beforehand in terms of the coordination of care. So we jointly operate across the system what's termed integrated discharge hub. So that has one person that leads the hub on behalf of all partners across the system, and that includes staff from mental health services, community services, the acute hospital. So we have just brought into that hub the discharge facilitators, whose role is to coordinate those care plans, ensure things like medication is ready. We know that's where some of the delays are at the moment. So that is part of our transformation improvement plans, working with the acute hospital to ensure that we've coordinated the discharge summaries being provided, the medication being available, transport being coordinated, that ongoing care is coordinated once somebody's discharged. So we know one of the challenges is getting people home earlier as well, that discharges tend to be late in the day, which impacts on flow through the hospital, and the ambulance is held at the front door. So the role of the integrated discharge hub is to better coordinate that discharge, so we know we can manage it in a more timely way. The out-of-area placements that you touched on does tend to fluctuate. So at MPFT, we hold the numbers for both Shropshire and Staffordshire in our numbers. We do have challenges in Shropshire because we don't have a psychiatric intensive care unit, so there is beds available in Stafford, but not necessarily to the level needed in terms of patients from Shropshire, so that drives some of our out-of-area activity. I'm pleased to report that we've got capital funding coming in that's going to enable us to build a PQ unit in Shropshire to address that. The other out-of-area activity sometimes depends on availability of PQ, so that's psychiatric intensive care beds. Again, we're doing work across the system in terms of making sure we've got the right level of capacity to meet those needs. And then the rest of the out-of-area placements tend to be those acute patients. We work extremely hard that if somebody is placed out of area, we try and get them back into the beds available at St George's quickly as possible, because we know the longer they're out of area, the poorer their outcomes are. So it's usually 1 or 2 days. We're doing work at the moment around length of stay across the inpatient wards, particularly around homelessness, because that's one of the things we're experiencing at the moment is the level of homelessness for the number of patients coming through the inpatient services in St George's. So we're working with local authority partners in terms of the opportunities around addressing that, and again, voluntary and third sector provision for us to better coordinate that. We do have a discharge team that reaches into all of the inpatient wards that's made up of social workers, so again run jointly with the local authority and MPFT. That serves us exceptionally well, because it means they can go onto the wards, identify people really early on where we know we're going to have challenges in terms of people's home environment or finding them suitable living accommodation, so they work really proactively in coordinating that care. But that does contribute to some of the challenges that we have, and it is maintaining that focus on flow as much as it is in the acute hospital that we see it with the ambulances. It's the same in terms of being able to manage flow and across our inpatient wards. I have to say our consultant psychiatrists provide great clinical leadership into those inpatient wards and making sure actually they're take responsibility for who absolutely needs to be in hospital and who doesn't, and how we wrap our crisis home treatment teams around there. There is more work that we need to do around our crisis home treatment offer and making sure that we've got the right facilities and capacity in place to be able to keep people at home if they don't need admission into an inpatient unit.
And obviously, just one last question, because I will admit, I mean, the staff do work extremely hard and quite often under a lot of pressure. What are you actually doing as part of this budget to protect the staff?
So I'm moving roles actually into Chief People Officer of the organisation, having taken all the learning. We've got a really strong wellbeing offer for staff across the organisation. So we have something called Soothe, which is effectively a support mechanism available for staff. We invest a huge amount into team development and team well-being, because we know one of the factors in terms of supporting staff resilience is that sense of connection and belonging to being part of a team and that well-being. So investment into leadership capacity to support that. We do really well in terms of staff experience in working in the organisation. So we're in the top 5 in terms of places to work across the NHS for organisations of our type, having just had our staff survey results published, but we know there's always more work to do. We have got teams that are incredibly precious, as I mentioned, our community nursing services. You know, we've got a 4% vacancy rate, which I think just demonstrates the people's commitment to the roles, that we're able to retain people in roles, but also do very well in terms of attracting people into positions. But we know the pressure that staff are experiencing in those roles, so wrapping support around them. We look at things like flexible working opportunities to be able to sustain people's work-life balance. But a lot of it comes down to making sure you've got good team functioning and the right morale and motivation and support from within teams, and that comes from the top of the shop all the way through the organisation.
Thank you very much. Is there any other questions? Mr. Bassett.
You talked a lot about, obviously, getting people out of Stoke Hospital. There's a big, long corridor called the A5 with a lot of hospitals on the other side of it, which a lot of Staffordshire people access, you know, particularly people in Lichfield, Tamworth, Cannock and so on and so forth. How connected are the services in terms of getting people out of those? And one of the things I came across as a health watch worker going round and about was finding people in the D2A beds in Tamworth Hospital from Codsall, because there's no D2A beds at all in South Staffordshire.
So that's one of the things we work really hard on, to make sure we've got an equitable offer across the county, because we know 50% of the patients actually flow either into Queen's Hospital or the out of area counties. So the offer we have is making sure that that's equitable for the residents of Staffordshire. It's slightly different in terms of the arrangements. We have a UHNM where we've got an integrated discharge hub. We have an integrated hub or transfer of care hub in the south of the county, but that functions quite differently given the amount of hospitals that has to interface in. So we are on site at Queen's Hospital, and we're part of the discharge lounge at Queen's Hospital. We have staff on site there. The transfer of care hub reaches into places like Good Hope, Wolverhampton, Walsall, Russell Hall, to be able to manage discharges. So they've each got their own discharge hubs that we interface with to be able to manage that discharge. And some of the processes look slightly different into the hub for us to be able to manage that. But we have the same offer. So we commission the voluntary sector to provide ongoing support for people at point of discharge in hospital. So Support Staffordshire hold that contract. So again, that's a county-wide offer that's available. Home First and the community hospitals, we work collaboratively with UHDB in terms of the provision of the community hospitals in the southeast of the patch. So we manage the admissions into those hospitals, so we know we've got an equitable offer, and we haven't got, depending on your postcode, you get access to a bed earlier depending on where you live. We know we've got a challenge in the southwest of the county, so we do work with an independent provider to provide care home beds in Stafford and Cannock. So we do have an offer available, but we don't have any community hospital facility. That is one of the areas we're keen to explore with some of the capital funding coming nationally, about whether we could establish a facility in the southwest of the county, given we've got Hayward Hospital in the north, the community hospitals in the southeast, but nothing in the southwest.
Other comment. I was talking to some patients in Uttoxeter recently, and they were saying the nearest community hospital facility to them that's on a bus route is in Ashbourne, but it's funded by the wrong ICB. Why can't we go to Ashbourne? We're a national health service.
I think the challenge is when you move over boundaries is the fact that all your wraparound services aren't there, so your social care assessments, the pathways are all delivered as an integrated offer, so you've got your medical input, your therapy, your social care. We use particularly the community hospitals effectively as a stepping stone to rehab people to the point that they can go home. So having them in county means we've then got those pathways to be able to transfer people then into home first, but absolutely get the challenge in terms of geographical location and which hospitals are easier to access.
Okay, thank you very much. Do you have any follow-ups? Okay. So, yes, thank you for your report. That was very informative. We are now going to move on to the work programme. However, I'd like to do a quick comfort break before we start with that. And then I'll expect us back here in about 5 minutes. Okay, thank you. Thank you and welcome back. So now we're going over the... I've forgotten what I was doing then. The work programme. That's it. Sorry, I literally just had it in my head as well. So for the work programme, where's it gone? I've lost it. Hold on.
Good afternoon, Chair. So yeah, this is just for the committee. Now, normally, the first meeting of the municipal year, the work programme goes first, but as you explained, due to officer availability, it got moved to the end, like it would in any other committee. So councillors have come up with suggestions, and there's an opportunity for councillors to do so today as well, where the chair has worked with myself and colleagues at the ICB and at the council just to try and plan out the work programme as best we could. So it's just for comment and the committee to approve it. Thank you, Chair.
Does everyone have the work programme in front of them? Has everyone managed to look at the work programme? Do we have any suggestions on the work programme? Or any comments?
Question. So we had the workshop, so you've incorporated all of the workshop elements. What's happened to the ones that were almost in the waiting line on the last year of work programme? Because we had a lot of things that were sort of not yet adopted as part of the agenda. They were there as follow-ups. Have they disappeared altogether?
So a lot of them have been. So you'll notice on the work programme it's slightly changed from last year in that now there's a scope column, just so that we can, when items are suggested, it's properly and thoroughly scoped out to the officers so that it's clear for members and for officers to what's actually being requested. A lot of the items that you're referring to have kind of been embedded within the other items within the work programme to make them a little bit more strategic than what they were. But again, that's a scope. And if there's anything that you feel is missing, then obviously that you've got an opportunity now, but at any point to raise that, and then they can get added in or added to a specific scope.
Councillor Griffiths.
Yeah, thanks, Chair. I'd just like to bring up the potential of the working groups. Like Mish has suggested we actually do two. She wanted us to do the winter plan, which we've been talking about for a while, but then she was talking about a deep investigation into the neighbourhood model that they're moving to. Obviously, for me, I think that's brilliant. Let's do both. I'm just wondering from you, Chair, and Zach, have we got the capacity and time to do two?
So working groups are established at each meeting whenever it's deemed to be appropriate. So at the next, and it's kind of a recommendation that would come from committee that committee would make to establish a working group. There is a suggestion of a working group stroke inquiry day on winter planning that in July, but again that would need to come from this committee. Any other working groups, it just come as and when if it came from committee.
So Luca.
Yeah, obviously because of the position we're in about the savings and all that, and the way it's like the new services rollout is going to affect the community, could we not actually include a community impact assessment on our work plan? Obviously how the change from hospital-based to community-based is going to affect the well-being and running of the services within our communities.
I think that's something that that could be a line of inquiries that you could use when these individual items come to committee. If it was something specific for an item that you wanted in advance, I'll work with officers to provide on behalf of the committee for the individual items to say, can you include this? It's all part of that scope I was talking about.
Thank you, Chairman. Well, I'm just looking at the items for future scrutiny, drugs and alcohol service, which is quite concerning, actually, when you think about drugs on the increase in alcohol, you know, and the effect it has on people's health, you know. But we're talking next year before you even look at that. So we're talking probably nearly 2 years away before we do any work on it. So I just leave that with thoughts.
Councillor Wallins.
Thank you, Chair. I would love to get some more update regarding the maternity services at Samuel Johnson. I know I keep badging onto it, but yeah. Okay, that's fantastic. Oh, October, fantastic. Thank you.
Is that everyone's suggestions? Oh, sorry.
Just a couple of comments, really, I suppose. Like you're talking about impact. Most of the proposals that are developed within trusts and organisations in the health service are supposed to have impact assessments as part of the business case. So I think you could build that in to some of the questioning when they come here. But there should be an impact assessment as part of the programme anyway. So I think, yeah, that should be covered. I think the winter planning stuff is really important, because that is a major issue and has been for donkey's years, hasn't it? I mean, I think I've been involved in health and social care for 54 years, and it's been an issue every winter for as long as I can remember. And I think I'm on about the 8th health service reorganisation in my lifetime, I think, so far. So yeah, there will be some bumps along the way with this reorganisation and the bedding down of things, won't there? And the money's going to be a thing to watch, I think, as well, isn't it?
Yeah, firstly, to respond to Councillor Luca's comment, this is exactly what I've been trying to say to the trusts. Give us some detail of how it affects us and how it affects the patients. Because unless we've got some specifics, it's difficult to know what the impact assessment's going to be. You know, they're talking at a very high level that various things are going to change, which are bound to affect the local authorities, bound to affect the voluntary sector, bound to affect the residents, but until we have any detail, it's difficult to react. That wasn't the reason I indicated. I just wanted to say that having looked at this, I think we've got all the right things in the right places. So Councillor Wallen's comment about maternity services and midwifery, I think that's ideal for October. I think elective care will be a good one to look at in November. And also cancer services. The one I wasn't sure whether members are aware of is when you're looking at the adult social care market, which is down as February 27, are members aware that the council has made the decision to extend the contracts for the aftercare services beyond their normal expiry date? So the council has decided to, because of what's happening with local government reorganisation, not allow them to run out, but to carry them on for at least another part year or full year, so that they go past the date of local government renewal. It's up for discussion actually on Wednesday in the Cabinet. And the principle behind that is that we don't particularly want to have a new authority having to deal with a contract for something it's never dealt with before. So if you imagine the new people involved in the new authorities. So looking at that, I think ironically, February 27 would be ideal to be looking at any potential for considering adult social care market, because at the moment we're not in the game of looking for anything new, but possibly by February we might know a little bit more about the structure of the new unitaries, and therefore looking at the market might be quite pertinent.
Everyone agrees that this is what you want to look at this year? Yeah? Okay, that's good. Okay, thank you. I'd like to close this meeting then, and we can all go home and have some snacks.